probably like the 70s, and he was sort of like a counterculture politician, and really gained a lot of attention for some. So he's a trained attorney, and but he got very political, and he's responsible for instance, for like seatbelts in cars, and he gained a lot of attention. I mean, there was times where his popularity was compared to that of the Beatles, because just like from a political perspective, and he had such a following, and he had this group of people that called themselves the Naders Raiders, and they'd go to Washington, and he pretty much was responsible for, the big one was seatbelts in cars being a law. But then also, I believe he was responsible for a lot of emission standards and like air quality laws that were enacted, and then also food safety and all the regulations that the FDA imposes as far as not the FDA whatever regulates quality of food to make sure you know what's in the product that you're buying.
I think it is the FDA, no? FDA.
Yeah, I guess. Well, it's Food and Drug Administration. Yeah, exactly. I always think of FDA with, drugs, pharmaceuticals.
Right. Yeah.
But it's also food.
So he does sound like a cool guy, and you interviewed him?
But then he actually ran for president as the candidate for the Green Party, and he was the one who, in the 2000 election, was essentially blamed for President Bush winning and Al Gore losing, because most people who vote for the Green Party candidate would have otherwise voted for the Democrat. Yeah. And so this was after 8 years of Clinton, and then it was Al Gore, the Democratic candidate, George W. Bush, and Ralph Nader. And he maybe had 6% of the vote or something, but certainly a substantial portion, enough to take away from Al Gore's. Yeah.
How intricate.
So, but he actually ran again he was the Green Party candidate in 2008 is when I interviewed him. He came to Vermont for like a political rally, and we were able to, it was when I had my public access show on Vermont Public Television, and we were able to secure just a 10-minute little interview with him, afterwards. So he didn't come on the live show. It was the one interview actually throughout that whole year of doing that show that I had pre-recorded, and we actually got to edit a little bit. So, but it was fun talking to him, and I still have the clip on YouTube. I'll show it to you sometime.
Yeah, 10 minutes. Express interview.
Exactly.
Well, we'll have about an hour.
Now's the time he should run.
Yeah, I don't know what he's doing these days. I mean, he's got to be in at least his mid-80s at this point.
But nobody would argue that that's too old to run for
president. At this point, yeah, that's true. That's actually about the right age to run for president.
Who would have ever thought that when you tried to run for president in your 60s or 70s, you were too soon?
Right,
you should have waited.
Yeah, oh my goodness.
So people really need you.
I can't believe it. You just look at, there's so many, such a variety of levels of physical fitness and various decades of life. I mean, in my line of work, I see people in their mid-50s who look like they are in their mid-70s, just because of, combination of genetics and what they've done in their life and how they've abused their bodies and choices they've made. And then there are people in their 80s who are spry, but I don't know that I've ever really met an 80-year-old who's spry enough to run the country, and that's really concerning.
Yeah, I don't want to run the country, and I'm in my 40s, and I don't think I have either the sufficient experience nor the stamina.
Yeah.
I lack both things you need from opposite sides of the spectrum.
Mm-hmm.
Are we recording?
We are.
Okay, you want to start officially?
Yeah.
Okay.
Yeah.
You want to introduce our guest?
I do. So our guest is our friend Marek. Now.
Yeah. Doctor.
Right, doctor. But I have totally blanked on now what you just told us. Your last name is
Maerk Hirsch.
It's tough because we've known each other in an entirely social, friendly, party, having fun type of relationship, and we don't know much about each other's professional lives. So, with the exception of once or twice, maybe you've actually seen me wear scrubs, and that's typically what I'm wearing when have the professional hat on. Yeah, but
even as a director, you wear scrubs.
I like to wear scrubs, because
People know you're in
I
it.
hate wearing ties, and you have a great excuse to wear pajamas professionally when you're a doctor. So
They do look very comfy.
Oh, it's great. Yeah, and it's the same thing every time. It's one of those decisions you don't have to make in the morning. Just black scrubs. That's it. Out the door.
So Dr. Maerk Hirsch is the director of psychology.
Oh my gosh. Okay,
All right.
Dr. Hirsch,
yeah.
how about you?
Yeah. Sorry,
Okay,
you
I'll
give
let-
us the introduction. Sorry. I'm brutalizing it.
I'm the chair of the Department of Psychiatry at Baptist.
That's it.
Baptist
That's a big
healthcare system. So this is, Baptist here in Northeast Florida. There's many Baptist hospitals, around Florida, but like here in Jacksonville, we have the Baptist healthcare system, largest healthcare system in Northeast Florida. It's 5 hospitals. So you've got the main campus at downtown. Then you've got Baptist South, Baptist Nassau, Baptist Beaches, and then recently opened Baptist Clay. So those are all, fully functioning hospitals of various sizes, and then we also have freestanding ERs. So at the airport and at the town center, over in Oakleaf, and there's a couple more coming online. So it's an expanding healthcare system, and it seems like every time they put up a new ER somewhere, like Clay, for instance, used to just be an ER, and then they built a whole hospital around it. So that's kind of the trend, is like see.
They're like, that's actually helping
what the
people.
demand is in
Yeah.
a certain area with an ER, and then like, we could actually use a whole hospital here. So I'm sure there's plans in the works for those other locations as well.
Doesn't Baptist regularly advertise specialty services as well, like maternity and things like this? It seems like I recall billboards where they were promoting this.
Yeah. So actually, there's been some renovations in the works for the maternity ward, which is nice already. My wife gave birth to my 3rd son there last May, and so she was admitted there for, I think, 3 nights.
Best review ever. The restaurant that the chef eats at is the one you want to go to. So that's
The review of the Baptist food.
well,
The
no, the
Baptist
maternity
maternity
ward. If that's where you, your wife
I understand.
chose to have your child.
Gotcha.
That's the best
Okay,
review
you're using
possible.
analogy, or a metaphor. It was. You're also kind of limited by what your insurance is going to cover, right? So when you're employed by Baptist, which I am, and then their healthcare plan forces you to be in network with their doctors and in their hospital. If you don't want to pay an arm and a leg out of pocket, you're going to go have your baby there.
The other doctors will spank you and your baby.
Right. So when I worked at Memorial Hospital for 4 years, we had 2 kids at Memorial Hospital.
Okay.
And then I started working at Baptist, and this one was born at Baptist.
So you're a hospital loyalist.
I'm just loyal to, I guess, to the insurance company by force.
And you're there so you can keep it.
I don't want to pay like the out of network fees. It's like both hospital systems are entirely competent and capable of taking care of a woman giving birth. So
There's probably some benefit though that they've got to look you in the eye the next day.
yeah, that's true. Actually, yeah. So the first time, this was a great 24 hours. So for the first kid, and my wife had C-sections, so I hope she doesn't mind me, giving information about her medical, history. But in any case, so
Do you have a waiver?
no, she won't mind. So she went into labor on a Saturday night, and it was a week that I was working, and I used to do a lot of electroconvulsive therapy. So I don't do it anymore at Baptist, but when I was at Memorial, electroconvulsive therapy is essentially, it's electroshock therapy. That's how people know it. It's used to treat a variety of mental health conditions, and I developed the program at Memorial back in 2018, and practiced there for 4 years, and treated many patients. I do about 10 patients a day, 3 days a week. And but always early in the morning. So in order to get the space, because it does involve anesthesia, so you need anesthesiologists and need a large space to line up 10 patients who you're going to anesthetize, electrocute. They need to recover, after they have a seizure, that kind of thing. And so we ended up in the hospital on a Sunday morning when she was in labor. She tried to have the baby without a C-section. We ended up, and the nurse anesthetist who was on call for 24 hours beginning Sunday morning was a guy who also I did ECT with, so I knew him well. And so he did her epidural Sunday morning. We were with him, all day Sunday as she was trying to, finish with the labor and have the baby. But then we ended up having to do a C-section that Sunday night. and he was the nurse anesthetist, CRNA, doing the C-section. So, did the epidural for my wife in the morning, was with us in the afternoon, ended up doing the C-section with her that night. And then the next morning was Monday morning, and I had 10 patients to perform ECT. And so he and I did 10 ECTs together while my wife was recovering. So it was a really fun 24 hours for us.
That is definitely what I would call a real shocker.
It was a real shocker, yeah. I mean, of course, people were like, are you going to take some time off? I said, well, we didn't know she was going to go into labor that day, and I'm here in the hospital anyway, so I might as well go do that.
I got some electrons that need to meet some people.
Yeah, while she and the baby are asleep, I'll go work for an hour. So
how long does this last, that therapy?
The ECT, electroconvulsive therapy. So it's what we use for treatment-resistant depression. There are a variety of treatments that are considered for treatment-resistant depression. ECT is one of them. It's been around since the 40s. So it was
with increasing amounts of consent, right?
And so it's right. I mean, it was definitely more barbaric, I would say, even. I mean, and everyone's seen those videos of One Flew Over the Cuckoo's Nest, which essentially tanked the ECT industry for about a decade. It is a very effective treatment, but
you definitely have this challenge, I think, of the public. There's a public stigma. It's even used frequently in jokes and humor. And
Right. Yeah, but I mean, it's literally. I mean, as psychiatrists, we refer to it as the gold standard of treatment for depression because it is that effective.
Wow.
Like any psychotropic medication that's developed, when we compare its efficacy, it's like how effective is this new medication compared to electroconvulsive therapy, and just nothing
for depression specifically.
For depression specifically,
what about schizophrenia?
You can use ECT to treat schizophrenia. It's not nearly as effective. It's more effective for mood components, for highs and lows associated with schizophrenia, which we actually would then call schizoaffective disorder, as far as the true psychiatric diagnostic term that implies schizophrenia has more to do with disorganized thoughts and delusions and hallucinations. Those symptoms don't really abate with ECT, but if someone also has highs and lows associated with that at least can improve. So they're not like delusional and manic or delusional and depressed. They can at least just be kind of
that is
baseline
really
delusional.
Wild. Just the idea, the deeper maybe meaning philosophically to the idea that when your brain is out of whack in a way that we don't to this day fully understand, that shocking it will reset it, will put it back to what it should be doing to a greater degree.
It's very much a reset. I mean, that's, each of these pharmaceutical agents that we use are, somewhat selective, to varying degrees depending on which one, as far as how they're modulating neurotransmitters. So some focus more on serotonin, some more on norepinephrine, some more on dopamine, some more on glutamate, some more on histamines, for instance. But they all are, a little more selective. Whereas ECT, it's just like opening a floodgate, like all the neurotransmitters, and just the brain then trying to kind of re-regulate and essentially reset itself. And it is effective.
Memory, short term or long term? Does it have any impact on memory?
It does. So that's the number one side effect or potential side effect with electroconvulsive therapy. And so it's something that we try to mitigate. So again, back in like the 40s, 50s, 60s, way back when they were doing it without even anesthesia. They weren't putting people to sleep and you have a bite block in, and that kind of thing. So now at least people are under anesthesia and we paralyze them. So you're not actually. So when you're anesthetized, right? we give them a paralytic. So then actually when you stimulate the brain has the seizure, but your external muscles aren't actually going to contract in a convulsive grand mal seizure type of way. We put a tourniquet around the big toe to avoid the paralytic from being circulated to the big toe. So that should be the only appendage that we see like actually moving. So we can tell there is a physical seizure going on. We'll see their little big toe convulse. And it's not a perfect science. I mean, sometimes you don't give quite enough and you see a little twitching or a little movement or whatever. But, I mean, it's not, no one's breaking bones and breaking
You
teeth
have much more control over the juice nowadays, also than what you see on TV with these two dial system, and then you've got a lot more fine tuning going on.
Well, on some of the more sophisticated machines, there's maybe 4 dials now, but
we're up to 4 dials.
The ones with the 1 dial still, it's all like automatically calibrated, and yes, the technology is much more sophisticated. The biggest thing, I mean, this is getting maybe into the science of it, right? That your audience might not really enjoy, but the biggest thing is that your brain has an electrical current, and but it's not the same type of electrical current that comes out of your wall socket. So if you've ever taken a basic physics class, the electrical current that comes out of your wall socket is called a sine wave. And as far as the electrons like oscillating back and forth and creating a frequency. And so but that's not how the brain operates. The brain operates more in a electrical current that looks like rectangles, and it's very sharp, abrupt inclines and sharp, abrupt declines, as opposed to a sinusoidal pattern. And so the machines convert the current that comes out of the wall into the current that is most consistent with how the brain operates. So by doing that, you need much less power from the wall socket to generate the seizure, because it's like because it's being converted to what the brain normally uses. So we used to have to, before that technology, we'd have to blast people with a current that's inconsistent with how the brain operates. And now we just have to use much less power, which means far fewer side effects as far as memory loss. We also, as far as where the electrodes are placed, there's techniques that we use to also try and avoid stimulating certain parts of the brain that have to do with memory, notably the hippocampus, that's your memory center, and we try to avoid stimulating that directly.
So the electrodes are more precise. It's not those 2 big things they just stick them inside.
It's still the 2 big things, but it's a matter of where you place them. So we start with something called unilateral ECT, where you put it, one temporally and one frontally, and you can stimulate kind of the frontal lobe of the brain, and that'll still induce a seizure. Not as effectively, but it is effective for, I would say, most people. But with those real severe cases, you do need to go bilaterally, but that's when you're essentially putting a current directly into the center of the brain, and that's where the hippocampus is. So then people are going to have a little bit more memory loss. Yeah, but it's more like short-term memory loss, and it usually stops after the treatment. So the recommended treatment's 12 treatments, 3 times a week for 4 weeks. So I mean, definitely, I'd be lying if I said that there are some people I'd be lying if I said no one has permanent short-term memory issues, that are prolonged after ECT. Some people do, but most people do not.
What made me bring that up is the idea in my mind as to how, at least in some people, depression must be connected to the way they're actually processing memories. Their issue has to in some way be correlated to how they're thinking about the things that are happening to them.
Really? Okay.
I'm not here to victim shame, so I know that language can sound awful close to that, and that's not my meaning at all. But I'm just suggesting that there's got to be a connection. But you were the expert.
Between depression and...
depression and how we think, how we go from an experience to a memory. Which is to say how we interpret or think about our world.
What we attribute to that experience.
Well, yeah, absolutely. So when you say that, I think of it both from a psychiatry perspective, like a biological perspective, and a psychology perspective. So from a psychiatry perspective, yes, when people are depressed, memory impairment is can be a symptom of depression, and it's actually something that we call pseudo-dementia. Meaning that and it's usually in older folks, but something that appears like someone's having memory issues, but it's really just a symptom of depression. And if you fix the depression, the memory issue goes away. From the psychology perspective, kind of address what you're saying. It's when people are depressed, they often misinterpret the world going around them because they're glooming and dooming, and they think that not like paranoid necessarily, although some people get paranoid, but what you're talking more about is what we use cognitive behavioral therapy to address, which is a type of therapy. It's the most common type of therapy in existence now, and helps retrain people's thoughts and thought patterns, how they're interpreting the world around them. So rather than thinking that everyone is negative towards them and that every action that they observe or that they feel victim of actually isn't them being targeted, like people trying to be mean to them, but actually there might be other reasons why, someone else in your environment acts a certain way and it's not because of you. But people who are depressed feel that way,
But it still feels like the chemistry comes first. Right.
In some cases, I think, I mean, correct me if I'm wrong, but you deal with cases where somebody comes to you because they have a problem. So you're not dealing in a lot of cases where somebody has a slight issue, or you're often dealing with people who have pretty serious issues, and as such, I think that a chemical approach, a neurochemical approach, is an important tool and a common one because you need abrupt change. But I think for the common person who doesn't yet have symptoms impacting their life, subtle tools are what's needed.
100%. Yeah.
But I don't think you go to a psychiatrist if you have like subtle nuances.
No, you watch podcasts.
You can watch podcasts, you can do yoga, you can go talk to a priest, you can do a lot of things that I tell people to do, but some
before electroshock therapy or after?
No, what you're describing, I agree with you 100%. You're describing the spectrum of individuals experiencing medical issues. I mean, this is true in mental health the way it is in any other, name a diagnosis, you're going to have a spectrum of severity and acuity, right? So some people are pre-diabetic, they've got a hemoglobin A1C of 6.2, which is borderline, and then you've got people with an A1C of 12 and they're in diabetic ketoacidosis every other week and hospitalized and in the ICU and having seizures, right? And it's like same technical diagnosis, but different severity. You name it, with congestive heart failure, COPD. I mean, you're going to have a spectrum. It's the same thing in mental health. I mean, on the inpatient unit, there are folks who are so profoundly depressed that they're catatonic and in an ICU because they haven't eaten or drank in a long time. And, I've brought the ECT machine to the intensive care unit and shocked people there, and, daily to try and help them. That's kind of one end of the spectrum as far as psychiatry. And then at my private clinic, Metropolitan Behavioral Services, which I'd mentioned to you earlier, we have folks who come in who need like a little sprinkling of Prozac and some psychotherapy, and they've never been hospitalized, and that's what will help them. So it depends on the person.
Now, I think the most complicated area in that spectrum is probably when somebody needs help but doesn't accept it. The most common example of that is in Florida, America, in the United States, I think, is under the Baker Act, when usually a family or a person close by has somebody involuntarily committed. Can you tell me a little bit about that, or what people might consider or need to think about if they or a loved one is experiencing, if they have a loved one that they're concerned about needing psychological health services, but they are at a dangerous point and won't accept help?
Absolutely. So many people in Florida are familiar with the Baker Act, which is what our involuntary commitment law is called in Florida. It's Florida specific, but every state has their own version of an involuntary psychiatric commitment. It's not a federal law that, they do vary state to state as far as the amount of time that someone's committed for, whether weekends count as part of that 72 hours, holidays, that kind of thing. I mean, I did my training at Harvard in Massachusetts for my psychiatry residency, and up there it's also a 72-hour commitment, but weekends and holidays don't count. So if you get, and up there we called it a Section 52 or a pink paper, because it's always on pink paper. If you got pink papered on a Friday of before Memorial Day, you're pretty much going to be locked up for like 5 days, because the long weekend doesn't count.
It's always. I just thought that was a bit crazy, because crazy people aren't keeping track of this stuff. They just are stuck there.
I don't think you should also call people.
Okay, I probably shouldn't call it. Okay, but I
not offended by it. It's
Okay, thanks.
There's plenty of people who are crazy. Yeah.
Yeah, I guess I feel
Yeah.
like I can use that word because I feel like I am, but I realize that might not
Well,
be
it's-
true
it's-
as well.
it's-
Yeah, I feel like because I call myself crazy, I'm free to call others crazy, but
I think Gnarls
I'm not myself.
Barkley said it best, right? You know,
yeah.
which that's you can when you edit this, you can play a little Gnarls Barkley.
Oh, we don't even
I
edit
think
it.
I'm crazy.
Yeah, I
So-
wish I could-
Yeah. So, but in any case, it is an important issue. It's something that I spend a lot of my time dealing with because clinically over at Baptist, I am predominantly in the emergency department. So I cover the 8 ERs and see all the behavioral health patients who come in, many of whom come in on a Baker Act, either initiated by JSO, Jacksonville Sheriff's Office. We occasionally get them that are initiated by a judge. Those are called ex partes. So essentially, that's when if you're, a family member and you are, because in order to Baker Act someone, you need to be either a law enforcement officer or a physician, or there's a psychiatric nurse practitioner with a certain amount of experience, or a licensed clinical social worker with a certain amount of experience. So those are the only individuals in society who can actually initiate a Baker Act. So you can't, if you were concerned about a family member that you really thought was going to harm themselves and they wouldn't come in for treatment and you didn't know what to do, and you're taking the firearms out of the house and you're locking up all the medications and
that's
et cetera.
The line you said, right, is if they're going to harm themselves or others, right?
Yeah, so you could, call, or the others, right? But so you could call a JSO and explain the situation, but the problem is, if they come over and that person is sitting calmly there and saying, I have no intention of killing myself, I don't know what you're talking about, and you have no proof. I mean, in this day and age, many people get Baker Acted because a family member will show a JSO officer, a Facebook message or a text message that says, I've been having thoughts of killing myself and this is my plan. Or, this is frequently happening, actually, with social media. People... I don't know, it's a cry for help, a cry for attention. It's incredible the number of people who end up under a Baker Act in the emergency department because of a post that they made on social media or a text that they sent, often while intoxicated. Someone gets drunk, they send a message,
They think they're going to get a reaction out of this other person.
Yeah, and then they pass out on the couch, and the next thing they know, they're being woken up by a JSO officer who's broken into their house, because
So not a good tactic for somebody to use who's trying to get back with their ex when they get drunk.
Correct. Yeah, exactly. I see this all the time. And this is the way the system works. So, but if you truly were going through the proper channels and it was a really legit concern, you could go to the courthouse and just like when you file like a restraining order against someone, that person is not there. You are writing an affidavit and presenting it to the judge, and they, based on what you've written, will either issue the restraining order or not. You can also apply for an ex parte, which means like ex parte meaning one party is not there. It's a single party, writing essentially a letter to the judge who will then maybe issue an ex parte order for JSO to go get that person, put them under a Baker Act, and bring them to the hospital. So that's the only mechanism that a person without some kind of medical license could initiate that. That being said, the vast majority of Baker Acts are complete nonsense that just clog up the system, the healthcare system, and are a huge waste of your tax money, unfortunately. I mean,
So in other words,
vast
do the
majority.
hard work and get the person help. Don't call the police because they're not there to help you. Is that a summary I can basically say?
No. The police typically do a fairly good job. They're doing their job. It's the folks who come in so frequently and manipulate the system because they are homeless, they have no money, they have no
I
food,
see. Okay.
and they come in and they say, I want to kill myself, and an ER doctor puts them under a Baker Act, which means they're at least going to get a night off the streets and in the hospital.
Not being attacked
they're going to
if they've
get
started beef with somebody.
Right. They're going to get some turkey sandwiches. And often, unless you have like a psychiatrist in that hospital who is willing to lift that Baker Act and discharge them, they're going to, end up getting admitted. They will end up in the hospital for days, and, you guys are going to pay for it. And this happens all the time, and it's an overwhelmingly large percentage of the Baker Acts that are issued, and it's really just complete waste and abuse in the system. I mean,
Would the solution for that be to have social services perform this role? Which we also pay for.
It's tough because I mean I on a daily basis, almost daily basis, will discharge. I will lift Baker Acts on people who are in the ER under a Baker Act, and I will discharge them while they're screaming at me that if I discharge them, the first thing they're going to do is go kill themselves. And I've got security walking them out, and they are threatening me. It's an interesting thing to threaten a doctor. Like if you discharge me, I'm going to go kill myself, and it's going to be your fault, and you're going to get sued, and you're going to lose your license because I've killed myself. It's going to be your problem. I'm always like, well, if you kill yourself, it sounds a whole lot more like your problem than it is my problem, you know?
This isn't a tactic you can use more than once.
Yeah, right. And it's just so, but it's like, it's such clear manipulation.
Right. Yeah.
But it is unsettling. I mean, I've been doing this for a long time. And so I'm pretty keen and you know, on my decision making.
What do you think would be the best solution?
Well, it all has to do with liability. I mean, they know exactly what they're saying. I mean, this is quite calculated, and it's why many physicians don't want to lift those Baker Acts because, if that person does go out and kill themselves, then, who's going to blame? Who's going to be blamed, right? Who's going to be sued? Whose license is going to be at risk?
The only solution I've ever seen work is in the Netherlands. They have basic social services. So if you don't have money and you need a place, there's somewhere you can go. And that way, at least they're not clogging up the prisons, the medical system. They're not.
Well, we have shelters here. We have Trinity Rescue Mission. We have the Salzbacher Clinic. We have the Mental Health Resource Center. There's a variety of places, right?
But aren't they over loaded? Was the
I think we still need more.
There's probably a need for some more of that.
And psychological health services that they have access to on the street.
Well, to a degree. I don't think that actually the problem is a lack of resources. It is a lack of people actually using the resources. And a lot of people just won't. And a lot of people, many of these individuals will instead just go from ER to ER rather than actually trying to address whatever problems that they're experiencing and go through the proper channels and make use of the help and resources that are given to them. You know, and it's when I see that, and it's wonderful now that we have, increasingly more advanced electronic medical record systems where we can see their records from other hospitals. We used to be blind to all this, but now I can see their records from Shands. I can see their records even sometimes from Mayo. I can't see them from HCA hospitals. They're not on the same system yet, but I can see St. Vincent's records sometimes. But to be able to share those records, and you see, like, okay, you were at Shands literally 16 hours ago doing the same thing, and they discharged you, and now you're here. Like, we're not going to go through this again.
It's also a lot of land to cover.
And I know they are impressive.
Yeah.
It is impressive how homeless people can cover massive territories.
Mm-hmm.
But
that's what you do.
I wonder also, though, if there's not a... when I see homeless people and they're asking for money, because I've directly brought some of these subjects to homeless people because I've got my opinions of which ones I like to give money to and which ones I don't. Not that I'm better for it, but I've got opinions, and it's a lot of them say that they can't get access to some of the shelters because they close at certain times or open at other times. And I recognize that they can try to get their stuff together. They're not exactly homeless because they keep a schedule and make appointments on time.
And that's true, but the hospital emergency departments are not an alternative to the shelter.
Right, yeah.
It's not an appropriate alternative, and that's where the abuse comes in. And that's when you just see, folks lying on gurneys in the middle of the hallways in these emergency departments, just, clogging up the system, abusing the system. And yeah, I mean, do you at some point feel bad a little bit? Like, okay, maybe, but, these are also, they're adults. And many of them have substance abuse problems. They don't have actually an underlying psychotic illness or something like that.
That was my question. So as a professional, you can see that it's pure manipulation of an
Yeah. There's
like
some.
100%
but even,
clear.
Listen, there are some people who
problems have psychological problems at their root.
They do, but it's... If you've been through that process multiple times, and every single time you're treated with respect by the physicians and the mental health professionals who clean me up, give you some food, provide you with all the resources that are available in Jacksonville, which actually are fairly robust. We've got Project Save Lives 7 days a week from 10 a.m. to 10 p.m. in our ER that specialize in placing people in substance abuse programs. Even uninsured folks with no money, like they will help them get into a program. Mm-hmm. Mostly it's Gateway here in Jacksonville, mm-hmm. but they will help them. And they are there in person 7 days a week. We have Lutheran Services, which help the chronically mentally ill also with lack of resources to get them mental health resources and appropriate treatment in an outpatient setting. You've got the Florida FACT team, which is if someone's signed up with the FACT team, and don't ask me the acronym, but it's essentially for seriously mentally ill people, and they will find these people on the streets to check up on them, make sure they get their long-acting injectable antipsychotic medicine monthly or biweekly, and really do a lot of services for them. You've got the Mental Health Resource Center, which is totally for unfunded people. You've got Salzbacher, which is grant-run. Dr. Colleen Bell, she's the director over there. She's a psychiatrist, does a wonderful job, taking care of this population, and both as an outpatient. They have a residential program. You've got the Salvation Army. Mm-hmm. There are an abundance of resources, but there are a lot of people who just keep shooting themselves in the foot. And it's like, how many times are we going to go through this?
Right,
we've given you all these opportunities 5 times in the last 12 months, and you keep then going out and smoking meth and then coming back in here thinking we're just going to do it all over for you again, and then even for the folks that are chronically, maybe truly do have an underlying psychotic disorder, I'm not going to, admitting them to the inpatient unit under a Baker Act 12 times a year is just, again, doing the same thing over and over with no different result.
Right.
And we give them the same resources every time. But, they seem to function out there. I understand no one likes to see them homeless and talking to themselves. But what else? An inpatient psychiatric admission isn't fixing them. And we've tried for years to help them. They are folks who need to be institutionalized, some of them. And we will eventually get some of them to the state hospital. But the state hospital system is overwhelmed. That's a whole other political issue that's been going on for decades as far as, shuttering many of these state hospitals where many people just need to live. I've worked quite a bit in state hospitals in Massachusetts.
Can you tell me a little bit about the difference between a state hospital and a private hospital like Baptist?
So private hospitals like Baptist, here in Jacksonville we have Baptist Hospital, Memorial Hospital, Shands, Orange Park are hospitals that have locked behavioral health units, where if you end up under a Baker Act, or you can come in voluntarily and say, hey, I'm having thoughts of hurting myself, I'm profoundly depressed, I really need to go for an inpatient psychiatric admission. We admit people. I prefer to admit people voluntarily.
How often does that happen by percentage in general? Is that a common thing or an uncommon thing? I think it would be a tiny amount.
I can tell you at this point that one of the things that I'm proud of, I've been at Baptist doing this for 2.5 years now. When I started, about 65% of the patients, of the behavioral health patients, were under a Baker Act. I've got that down to about 30% over the last 2 years because of just training, mostly with the ER physicians, of people can come in voluntarily and go to the psychiatric unit. And we don't need to Baker Act everyone. And so we don't need to treat everyone as some involuntary patient, because it does have repercussions. When people are under Baker Acts, the biggest thing is, first, you can't join the military. And secondly, if you have any kind of divorce or child custody issue going on, I have seen so many ex or soon-to-be ex-spouses who love to waive someone's psychiatric history in front of a judge and say this person is unfit to take care of our mutual child. And if you're involuntary, that really changes the game than if you voluntarily go and say, I need some help today, please admit me, right? It really changes the dynamic there. So we prefer voluntary admissions, and that's fine. But so the units like I described, and also in Jacksonville we've got Wekiva and River Point. Those are freestanding psychiatric hospitals that are fairly large, but these are all places where people might stay between 3 to 5 to 7 days on average. Our average length of stay on our unit is around 5.5 days. So it's to take care of someone when they're in that acute phase of safety, where safety is the concern.
And a state-run hospital is longer?
State-run hospital, you'll have people who are admitted there for 7, 8, 9 years or longer. I mean, it used to be, people used to stay there for life, but then it was really during President Kennedy's tenure that they tried to sort of like decentralize and and close the state hospitals and reintegrate this population of mentally ill individuals into community settings. And that was the idea, that rather than essentially housing all of them in state institutions, that we would have like community facilities that would be able to accommodate them and try and integrate them more into the fabric of everyday society, rather than kind of shuttering them in a state-run facility like that.
Is there a huge disparity in the aesthetic, and is this an attempt to mitigate some of that, inevitably different institutional look that you get with a state-run institution, to kind of make it seem
that it was a completely unrealistic, starry-eyed thought that some politicians had and ended up passing and enacting, who had, from as far as I can tell, zero information about what the reality of mental health care is like. I'm sure there were psychiatrists at the time. I mean, I wasn't alive in the 60s, so I don't know exactly, what kind of efforts were being made. All I know is that, as I mentioned earlier, I've spent quite a bit of time treating patients in state hospitals in Massachusetts, and there are many, many people who absolutely can never be discharged. There's no way they're ever going to be able to take care of themselves and be in the community. And they are treated very nicely at the state hospitals. They have many opportunities to be outside. Many of them are on amazing pieces of property where they used to have farms and all kinds of, outdoor kind of like, almost like, occupational therapy for people. I mean, you need to do something if you're going to be there for the rest of your life. I mean, they would really treat them quite well. But now there's this idea that we're always working towards discharge. Even though someone's been here for 7 years, we're still working towards discharging them. I can't tell you how many people I've seen in the ER who were discharged from one of the Florida state hospitals after being there for 7, 8, 9 years, and literally within a month, they're in my ER, and we're admitting them to the inpatient unit. And
that's kind of reasonable, because
it's like really they're ready for discharge. They've been there for 9 years, and you fixed them up so well.
They have trouble adapting, and then you stuck them in a totally different environment, and now you're just going to throw them out in the world to adapt.
Yeah.
I don't think, and I know that there's a process. I'm aware of that. I know it's not night and day, but I think it's a person that inherently has a problem with this, and now they have to deal with exactly that issue.
And you understand how much more expensive it is. At least if someone's stably admitted to a state hospital, it's like, I mean, there's an expense to the taxpayer of caring for that individual. Fine. It is considerably more expensive to have that individual now constantly admitted. It's the most expensive thing is to have someone coming into an emergency room and going through the admission process onto a psych unit. And by the way, to then get them readmitted to the state hospital is usually around a 6-month process. So now a place like Baptist, might have this individual on the unit, and we recognize they need to go to the state hospital, but the state hospital says, great, maybe we can take them in 4 months or something. There's a waiting list and a whole legal process you have to go through. So the expense of the legal process also. And in the meantime, in fairness to Baptist or Memorial or Orange Park, wherever this individual ends up, whatever insurance they have is not going to pay for them to stay there for 4 months, because the insurance companies pay for acute stabilization. Okay, this person, is having another psychotic episode. You brought them in, you got them back on their meds, and they seem stable. Are they saying they want to kill themselves? Are they attacking other people? Are they doing, these kinds of acute things? No? Okay, then they should be discharged. Well, Mr. Insurance Review person, they just spent 9 years at the state hospital.
Yeah.
They're clearly not surviving in the community. They need to go back, but we can't get them back. What Aetna, Cigna, Blue Cross will say, well, that sounds like a whole lot like Baptist's problem and not our problem. Click.
Yeah, I feel like I dealt with exactly that problem when just a few years ago, maybe 2 years ago, Alexandra and I we were the first responders up the road to a boy who was shot. The girl who shot him, I had seen her a week or so prior. I don't remember the exact amount of time, but not long before. And she was walking up and down the street, shouting obscenities at nobody, and just behaving in an extremely crazy is my term. It might not be the best.
And she didn't. I mean,
I'm gonna
she
stutter
didn't create an impression of being a threat. She was just, yeah.
Well, she only wasn't a threat because she was by herself in the middle of the street. I wouldn't have wanted to be anywhere near her. I remember thinking wherever she goes inside of a house, I would feel bad for anybody else inside that house because that's going to be a difficult life. And I saw her again sometimes saying and acting crazy and twitching and walking up the street. But I thought, like, maybe I should do something. Should I intervene or what should I do? But she's not my family. She's not doing anything actively to anybody. So as far as I know, it's a complicated situation. But I have no role there. I can't insert myself, or I'm creating a problem. So and especially I'm a little bit sensitive of the fact that she's a black woman and I'm a white man in a society where that is always going to be a component of whatever interaction we have. So, but sure enough, I don't do anything to her being in the street, and she's gone after a while and in some house nearby, obviously, because I don't think she could drive. And short time later, she's shot a boy 3 times, and we're helping this boy, get to the emergency room. And of course, it runs through my mind: one, who gives a person like this a gun? How does she get a hold? She could steal it, I guess, or get it from somewhere. But and then finally, what services? What do we have to do for people like this? Because she wasn't comfortable. I don't think she's saying to herself, "Oh no, I'd rather run around crazy doing these sorts of things." I think she's somebody who doesn't have a lot of resources. A family member probably struggling just to take care of her, and she's probably going in and out of the system with services exactly like what you're talking about, with people saying, "Well, we need to release this girl. She's behaving today, so let's put her back out." Because otherwise you're paying a small fortune for her to be Baker acted I don't know how many times, sit in medical facilities and jails I don't know how many times. Because in my rough view, we don't have sufficient facilities for people like her or the amount of them that we have.
Yeah, and there's a variety of things that might have been going on with her. I mean, of course, there's many drug-induced episodes that like you're describing. I mean, people, methamphetamine is very popular. Crack, it can make people psychotic and manic and, behave this way. But yeah, then there are individuals who, without any drugs, naturally will have episodes like this.
I imagine, I'm guessing here, but I imagine she had a background of all of it. I think she probably grew up in it. Drugs, no drugs, it's going to be crazy town either way.
Yeah. So she either needs to go to a drug rehab or we call it a dual diagnosis program where they get treated for mental health and for drug abuse. But at the end of the day, there is also only so much you can do on an involuntary basis. If someone's behaving psychotic like that, then you can Baker Act someone. Baker Acts aren't just for suicidal or homicidal thoughts or intents. It's also for someone who's so psychotic that they can't care for themselves. So in that situation, you could Baker Act someone who's behaving that way.
What an intense conversation. I actually have a question as we were going through all that.
Yeah.
How do you take care of your mental health after a few shifts in the ER?
Is it contagious? Do you catch crazy?
No, really. Because whenever, as you mentioned, we always see each other in a social environment, I always have an impression of you being just always uplifting,
happy,
funny. How do you do that?
What
do you do?
I've been doing it for a long time. I had my first job on a psychiatric unit when I was 20. I was in New Orleans and lived with my sister there for a summer. And it was actually 2005. I left the day before Katrina destroyed the city, and so that was an interesting time to be there. But I got a job as a mental health tech, so like a $13 an hour job, just on the psychiatric unit at Toro Hospital over there on St. Charles Street, if I remember correctly, and serving meals to the patients, helping them with their laundry, doing the 15-minute checks. Just on a psych unit, you have to know where everyone is every 15 minutes minimum. Sometimes someone's on a 1-to-1, and if you're assigned to that patient, you have to be within arm's reach of them for an 8-hour shift. It's a tough job. And so, that was where I got the start, and then I decided, after a couple months of doing that I wanted to go further with my education, and I got to know the psychiatrist who was on that unit mostly, and he kind of inspired me to go on to then pursue medical school and that sort of thing. So I bring that up because I've been doing this for a while. I'm about to turn 40, and so it's been 20 years really that I've been in the field. And I've had other types of jobs too. Even before medical school, I worked in residential programs, that kind of thing. So I think that I've just been very well adapted. I think I naturally gravitated towards it because I was interested in the patients. Some doctors are really interested in the heart. Some are really interested in the kidneys. Some are really. I just always had a inclination towards behavior and mental health and mental illness, and so I think you find kind of where you fit in, and it just always felt natural. And there are some times that there are disturbing things that have happened that I see, but I've kind of dulled myself to it, and sometimes just talking about something with my wife is helpful, but I don't really let it bother me at this point. I'm able to really compartmentalize and separate things. Sometimes an IPA helps, that kind of thing.
I see all of society as a process of making taboo palatable through concession. You create some buffers, and in those buffers is a good humor, and otherwise the whole world is actually shitting, fucking, pissing. It's all the things you're not supposed to say, all the things every human does, and they're all the things we're not supposed to really talk about on a basic level. Which is why medicine is amazing, because you guys have the view that nothing human is foreign in the range of the mind.
Right.
That's quite slippery slope for a lot of people.
Yeah. It's and just like anything in life, things get normalized, right? I mean, me walking onto a behavioral health unit or into the ER is as normal as you walking into a yoga studio, or you walking into a virtual reality studio, doing whatever it is that you do, and that kind of stuff. So it is. I can't help but be entertained, a little sadistically, I guess, when I end up admitting someone who has never been admitted to a behavioral health unit before, has never been on one, who is like a relatively high functioning, maybe like upper, demographic, upper middle class individual.
We can hit it with a real glass onion scenario.
And when the first like 15 minutes that they walk onto the behavioral health unit, and their eyes are like, like saucers, just so scared. It's like, must be like the first time someone walks into jail or something like that. But they get used to it fairly quickly, and it's not like it's a bad thing, but it's alarming, it's startling, it's a different environment,
Yeah, I can imagine.
It's not something that people are normally accustomed to, which is I don't I take for granted, because it's
You think
my
you'd be
life.
good with horses? If you were a cowboy, you think you'd be able to use the same techniques to wrangle horses and get them to
Maybe, I don't know. I don't have like such a huge inclination towards animals. I didn't really grow up with many animals.
Does
so.
it translate to like Skinner's approach? Does human psychology translate to animal psychology?
Yeah, well, he was very like behaviorally focused, and so like how animals are driven by rewards and that kind of thing. You have the Skinner box, and trying to train animals in various ways.
You're in my Skinner box.
I am. Yeah. That's a whole other separate discussion, I guess, about Skinner and his pigeons and Skinner
just
boxes.
Because we're kind of. Can we talk just a little bit about your private clinic?
Yeah, sure. Yeah. Hey, one thing I just wanted to mention, just because, just based off what Bill was saying, because an analogy that I like to give sometimes. Maybe it's helpful, maybe it's not. And, to anyone who is listening, I mean, I hope people aren't, like, horrified thinking that, my God, there's a psychiatrist who's so insensitive to the behavioral health needs of the chronically ill. It's like, listen, like, if you think that, I promise you I know the chronically ill way better than you do, and I'm telling you how things are, how things work, okay? there is, as we talked about, a spectrum of acuity as far as behavioral health problems, but you have to look. I look at behavioral health and the brain the way a cardiologist looks at the heart, the way anyone might look at any other organ of the body. Yeah.
Right.
And so there is such a thing. The way you have stage 4 pancreatic cancer, like there are stage 4 metastatic mental health problems. And I don't mean like that in the sense that there's a brain tumor.
Right.
I'm like, as far as the severity, like it's incurable, like stop providing the treatment, right? So if you have just an incurable condition, like just severe congestive heart failure with like a minuscule ejection fraction. I mean, there's just very little that people can do. And at some point, you have to let patients expire. And they make that decision, and they make it with, hospice or palliative care. At some point, the oncologist is going to say, no more chemotherapy, no more radiation. There is nothing that we can do. This is end stage. And the same thing exists in behavioral health. Not to say that those folks are going to die on the street, but I relate it to what we were talking about with the state hospitals, where there are some folks that are chronically mentally ill. They are never going to get better. They are never, ever going to care for themselves in society. It's stage 4. They need to be institutionalized. And that's it. And they can live a very happy life there,
They just need compassionate care.
Yeah, I think it's almost
somebody to care for them compassionately for the rest of their time.
I think it's more inhumane to try and entertain the notion that they're going to be they don't want to be discharged. They don't want to.
It's not that you want to return them to the street. You just don't have, your facility is not tuned for that. It's not that you don't want them to be cared for compassionately.
Right.
You simply have to delineate the line where your institution can help and in what capacity.
Right.
Versus.
And also, I do think of things from an economic perspective. I mean, why are you going to continue to spend hundreds of thousands of dollars providing the latest oncology treatments to people who literally have no chance of benefiting from it? Why are we going to spend hundreds of thousands, millions of dollars, admitting, discharging, readmitting, discharging people just through the cycle of various emergency departments and psychiatric units? How much money are you going to spend doing that just because, society thinks, anyone at some point should be appropriate for discharge back into the community? No, keep them in the institution. That's where they actually really want to be.
Well, Jacksonville has a good system relative to Florida, but as somebody who spent 7 years living in the Netherlands, I can say that I've absolutely experienced, and also in Germany, I've experienced systems that have done far better by establishing better minimum standards for their population and have a lot of money, a lot of tax money being allocated to social services to take care of those folks, because it is expensive, but it's less expensive to take care of them, understanding, like you said, who needs this type of treatment versus who needs compassionate care, who needs medicine, who needs counseling. And I find that they do a very effective job at that in many places around Europe, and that the Netherlands and Germany are a better example, and that's something we could look at. We have different whole economies. We can't clone what they're doing.
Right.
But I can say that we have a sufficient economy that I'd like to see us improve those minimum standards of care. Not at your facility. Your facility is not for setting the floor. Your facility is for treating people who have who want to put some of themselves and some resources into their own care. But we need to have, I think, plenty of other facilities that do have long-term compassionate care for people who, like you said, they're never going to be able to take care of themselves.
Yeah, and those are admirable healthcare systems. They work quite differently. They're mostly socialized, government-run healthcare systems. But and one of the larger things is you don't have a litigious population. You don't have a society of people that are just salivating over the thought of maybe suing a doctor, right? So that's a big part of it as far as how doctors practice medicine. And in my field, whether we're admitting or discharging or doing whatever, allowing people to manipulate things, that's something that is not an issue that they have to contend with. So they probably don't have a population of people than just trying to milk a very expensive system, as opposed to those same individuals, being part of the fabric of the community resources that you're talking about.
Yeah, because there's certainly issues where the Baker Act system is one that needs to be in place, but it shouldn't be abused.
Yeah, but it's really hard. Yeah, it's something that I'm racking my brain constantly about, and it takes a lot of political will, and it's just to revise it. I don't know, but it's truly it does create an enormous amount of waste and abuse, and just there's the vast majority of people. I mean, statistically, the vast majority of people who actually kill themselves, actually make a serious suicide attempt, and those are the people that it's trying to help, right? At the end of the day, that's who we're trying to help, are people who actually might kill themselves, not people who come into the ER saying, "Oh, I'm suicidal." The statement "I'm suicidal," and this is one thing that I educate the ER staff about, "I'm suicidal" is not a statement of intention. "I'm suicidal" is a symptom of a addiction problem or a personality disorder. It is someone trying to be manipulative, and because people who actually try and kill themselves don't come into an ER saying, "I'm suicidal." They go ahead and try and kill themselves, and then they end up in an ICU. They don't come into the ER voluntarily saying that. I mean, with some degree of in between, there are people who are having some thoughts, but it's not all the time, and so I'm describing kind of two ends of the spectrum, but for the vast majority of people who actually complete suicide, it's a minuscule portion of them who have actually accessed any kind of mental health care at all in the previous 6 months. So if you look at, and this isn't a statistic that's fairly reliable, because you can look at people who actually committed suicide. We know they killed themselves. Did they access any kind of mental health care? Did they go to an ER? Did they go to a psychiatrist, a therapist, a social worker, anything in the last 6 months? And like 80% have not. So that's the vast majority. They're not. How do you access it? How are you going to know that they're trying to kill themselves in the first place? How do you know to reach out to them? Like, how do you know to Baker Act them? So now we're talking about 20% who've actually accessed some kind of mental health care. How many of those individuals are accessing mental health care by going into my ER? Cut that down to some kind of tiny percentage. That little tiny percentage is minuscule compared to the overwhelming majority of people who come into the ERs saying, "I'm suicidal." That's the problem.
Yeah, it's almost like the problem of having a bunch of people from a crappy restaurant come over to your restaurant, which is supposed to be a nice restaurant, because there's a crappy one nearby.
Are you hungry, Bill? You like?
I am. I'm
do
hungry.
it always.
Yeah. Talk about food.
Yeah.
But it's a real challenge, because you don't want to provide less good care. You don't want to provide less good services.
You don't want people to slip through the cracks.
Yeah.
But I have had patients who have made serious suicide attempts. I've had patients jump out of 7th-story condominium buildings. I've had college students blow their brains out with a shotgun. I've had, people who came into the ER and in the waiting room took an entire bottle of medication that I had prescribed to them just earlier that week. I've had many things like this happen, and those are the ones who don't come in saying, "I want to kill myself." It's really and those are the ones that you have to try and catch before they slip through the cracks. And then there's only so much you can do. And each of those stories and the many others that I have are a whole nother conversation, about those individuals. But the
only way to do it, I guess, is to someone like you on the inside, kind of knowing what's what, because otherwise you're like a church with the doors open. You can't close the doors, or you're not a sanctuary.
Right.
That is a very difficult.
We're not a sanctuary. We're an emergency department, and it's like people need to respect that. I remind people of that. I say, listen, we're not a jail. Don't treat the nurses like they're security guards. Because some people try and do that. And we're not a shelter. We're a medical facility providing medical care, and we'll do that if you want to take it seriously. But otherwise, if you're not going to take it seriously, get out.
Yeah.
That if you're not going to take the mental health care that I can provide you with seriously, then leave. And I have no problem discharging you.
Yeah.
That's the approach that I have to take.
So any viewers, if you're watching this, if you have any experience and you need help and you message us, we will relay you to professional counselors who have a the appropriate care for the scenario that you're in. So
how are you going to relate? Just advising on those. That's a
Yeah, I'm
very
not-
long list of
I'm not
organizations, by the way,
I'm
you
not
mentioned.
a counselor, but if anybody
The-
messages me subsequent
Oh.
to this show,
Right.
I'm gonna put them in touch with the
that
right.
was thank you for saying that.
With
Yeah.
the-
Well, you asked about the outpatient clinic. So if you know, I imagine if there is anyone watching who's in need of mental health care around here, you know, I do have my outpatient clinic called Metropolitan Behavioral Services. It's on Salisbury Road in Jacksonville. I'm the medical director there. We have 5 psychiatric nurse practitioners who I supervise. We have a child psychiatrist, so we see patients across the whole life spectrum. We have 5 therapists there as well. We see all of our patients in person. There are many, many, many options of telehealth, telepsychiatry, teletherapy these days. And if you want to talk to some person sitting on a couch in Brooklyn who has a Florida medical license but has never actually been to Jacksonville, then you can
Right,
go
yeah.
to one of those services. But we are in the industry or business or whatever you want to call it of seeing people in person. So we're happy to. We have a very nice office over there, and again, it's
I hear
called
that's psychologically
Metropolitan?
very healthy.
Metropolitan Behavioral Services. Yeah.
I hear it's psychologically very healthy to see people in person.
Yes. Yeah. We prefer post COVID. It was hard though to drag the staff back in. Everyone, you know, they all had the, you know, the inertia of, oh man, working from home is nice. It was hard for me even, but we had just leased this brand new office space, and it was empty then because of COVID. And I think it was January 2022. Yeah, so I think it's been 2 years ago that we like essentially told all of our staff, okay, you can either leave or you're coming back in the office. And everyone came back in the office, so that was good. But yeah,
That is good.
We're not doing virtual.
It means you got a strong enough family to survive people who are doing things they don't want to do,
Yes.
which is hard nowadays
Yeah.
because there's a lot of options out there. And people, when they go home, they're online. You can see them all.
Right. That's true.
So that's really great. Well, thanks for joining us today and telling us so much. Every single one of these podcasts that we have, I learn more about people that I've met and already spent time and spoken with on multiple occasions. This is no exception. It's been a really great honor to.
And I think it's a
know more
very
about your work.
relevant subject also. Yeah, on many levels, politically, economically, socially.
That's right.
Yeah, so we have to have you back to talk about other things as well, about your other enterprises or undertakings, I don't know, ideas.
Yeah, I didn't even get to talk about the ketamine aspect of the clinic.
That's the only reason you wanted to have Dr. Hirsch here, right?
No.
Well,
I always, for our viewers who may know, I've had a fascination with psychedelics for a long time. So I do.
well, yeah, we'll have.
But we didn't get to talk about that. But I am also very interested in the psychology of it. We can talk about that as well.
No, and to even talk more about the Metropolitan Behavioral Services Clinic. Yeah.
Yeah.
Link down below, down on my knee.
All right.
So
Well, thank you again. For
Thanks so much.
finding
Yeah,
your
thank you for the coffee.
time.
yeah, really appreciate it. We'll take a break now and see
Functional
if we can
mushrooms.
go to lunch.
All right.
Yeah. All right.